Thank you to Reverend Knott. Thank you to the committee for organizing this. Thank you to President Lambert. And a special thank you to the Rogers family. Mrs. June Rogers, thank you so much for putting on this amazing legacy for your family. This is an amazing honor to follow in the footsteps of the folks before me. So I'll try the best I can to live up to the high standards that you've set here. So tonight's topic, as you heard, is going to be healthcare, and specifically a little bit about our faith community role in healthcare in the United States and beyond. And I thought I would begin by telling you the story of a recent house guest of ours. As Reverend Knott mentioned, I teach at the Indiana University McKinney School of Law in Indianapolis, and that's where I live. And so we had a recent house guest in our home in Indianapolis, and her name is Nicole Smith Holt. Nicole lives in St. Paul, Minnesota. She is a financial aid counselor for a college there. And the story is about Nicole and her family, in particular her son, Alec Smith. Now, Alec Smith was diagnosed a few years ago with type 1 diabetes. And probably most of you in this room know that a person with type 1 diabetes must have insulin every day to survive. People with type 2 diabetes, there's a lot more folks like that, and we may know some folks with type 2 diabetes. They oftentimes need insulin to survive, but a person with type 1 diabetes must have it, and must have it every single day. So a few years ago, in 2017 to be exact, Alec was turning 26 years old. Now, that's an important birthday in the United States healthcare system. And those of us with adult kids, those of you who are students, fortunately, hopefully you're not looking at that with too much trepidation yet, but you might. Because that's the age when an adult child ages off their parents' health insurance. And pretty typically, parents have access to better, stronger healthcare and health insurance than young people do. And that was true for the Smith Holt family too. Nicole had good health insurance through her work at a university or college. Alec worked full-time, didn't make bad money, but he worked full-time as a restaurant manager. And folks working in the service industry in particular, but a lot of other jobs, do not have access to good health insurance. So this is really important when you're insulin dependent, right? He needs that medicine every day to survive. So the family knew this birthday was coming, knew this deadline was coming, and they did their due diligence, they did thorough research, and they looked, again, this is post-Affordable Care Act, the best possible insurance that Alec could get. And the best possible insurance that Alec could get was going to cost him $450 a month for a premium. Now, $450 a month for a premium is a lot of money if you're a restaurant manager, but Alec was ready to pay that, and he was ready to figure out a way to pay that. But it wasn't the end of that health insurance story, because like a lot of other folks, he had a very large deductible coming. In fact, his deductible was $7,600, which if you don't know health insurance too much, that means that Alec was going to have to pay $7,600 out of pocket before that policy at $450 a month was ever going to pay for anything. So the family was in a tough spot, Alec was in a tough spot, and he made a decision with the family's support that seemed like the logical decision at the time. And that was, since he was going to be paying so much out of pocket for so long anyway, he was going to go without insurance, he was going to keep working his job to make his income, he was going to look for a better job, or at least a job that had better insurance. He may take a pay cut, but he'd have better insurance if he could do it. So that was what they decided to do. And Alec was living alone at the time, just recently had left the family home. And at the first month after aging out of his mom's health insurance, he went to the pharmacy to buy his insulin and supplies for the month. Now, if you know anything about insulin, you know the price of insulin has gone up and up and up. In fact, the very same vial of insulin that cost $28 for sale in the late 1990s, the very same formula is now costs $300. The price has gone up 1,000+%. And so Alec knew that. Alec knew the price was high. In fact, somehow he had managed, his mom says today, he's not sure how he managed to do this, but he scraped together $1,000 to go to the pharmacy with. Because $1,000 is what it had cost the previous month for his insulin and supplies. But the price had gone up again. The price was now $1,300 for his month's insulin and supplies. $1,300 for the very bare minimum for him to stay alive for that month. And so Alec didn't have it. He didn't have it, so he made a decision that 1 out of every 4 people in this country with type 1 diabetes say that they've made themselves, and that is that he was going to ration his insulin. He was going to take less than his physician had said he needed. He was going to take less than he knew from his own body that he needed. But rationing insulin is a very dangerous act. And in fact, June 27th, 2017, an otherwise healthy Alec Rayshon Smith was found dead. Alone in his apartment, he had died a painful, wrenching death from diabetic ketoacidosis because his body did not have sufficient insulin. Now, I tell you this story because we got to know Nicole and got to know James, his father, but it's not an outlier. 20-year-old Sarah Broughton, I imagine if we had to raise a hand to some of the students here, you got some 20-year-olds in this room. 20-year-old Sarah Broughton, like all of you who are 20 years old, like me when I was 20 years old, had dreams. She lived in California. She wanted to work with special needs children. But she didn't have health insurance either. Now, she didn't have a chronic disease like Alec did, but she developed a sinus infection. Sinus infection can happen to any of us. But she couldn't afford to go to the doctor. And it got worse. And she still couldn't afford to go to the doctor. And it got worse again and more painful, till finally, in agony, she went to the emergency room. But it was too late. The infection had spread to her brain, it had caused swelling, and the damage was fatal. Just a few months ago, you may have read about this because it actually made quite a bit of news. Hedda Martin in the state of Michigan was told by her physician she needed a heart transplant. Started getting ready for the process to getting the heart transplant, but then the hospital committee in charge of moving that process forward said, wait a minute, I don't think we're going to do this. And they wrote her a letter and said, we're not going to do the heart transplant, quote, due to needing more secure financial plan, end quote. And then they suggested she conduct her own private fundraiser to cover the costs of the surgery that would save her life. These are not isolated examples. These are not outliers. Nearly 2/3 of people in this country report that they skip health care every year. They don't go to the doctor, they don't fill a prescription, they cut their pills in half, what have you, because of cost. Many of those folks do have health insurance, but they have the kind of high deductible health insurance plan that young people are so often forced into, which means they're going to have to pay out of pocket, and if they can't afford to pay out of pocket, they're going to skip their prescriptions. They're going to go without care. You know the website GoFundMe, right? The website GoFundMe each year has 250,000 pages. 250,000 pages devoted to people from this country who go online and beg strangers to help them pay for the health care their care provider has said that they need. And for those who do obtain care in this country, especially if they have to go to the emergency room to get it, it often comes with a side effect. And the side effect is debt. Side effect is debt. And lots of it. 1 out of every 4 Americans under age 65 are carrying past due medical debt right now. Healthcare costs are the leading cause of family bankruptcies. And we know the statistics, and we know what they lead to. They lead to pain, they lead to suffering, and they do lead to death. It's not just Alec, it's not just Sarah. There are multiple published research estimates saying tens of thousands of people a year in this country are dying because they can't afford the health care they need. And that means millions more are suffering. And with millions more suffering, it probably means that folks in this room, that we know some people who are going without the prescriptions they need, going out with the care they need, delaying the care that they need, and sometimes in a painful and dangerous way. And I know that's true in southeastern Indiana. In our law school clinic, we partner with Indiana Legal Services. Through that work, through advocacy work, I've talked with folks throughout this state, and we certainly have represented a lot of folks in central Indiana who have gone without the care and the medicine they need because they simply can't afford it. I was at a meeting not too far from here, not too long ago, of persons with type 1 diabetes in a basement, in a library basement, and the folks there were talking about their own challenges, and a young man who was about Alec Smith's age admitted he has a full-time job. He doesn't know how he's going to afford his insulin each month. And he, like Alec, was rationing his insulin. So keeping that in mind, I'd like to tonight pose one observation and pose one question. The observation is this, is that when we look at this unrelenting suffering all around us, the people dying, the people in pain, the people struggling because they can't afford their health care, that's not a health care crisis. That's a moral crisis. It's a moral crisis for us and for our communities. So that's the observation. The question I'd like to ponder with you tonight is this: what are you and I called to do about it? What are we called to do about this moral crisis right in front of us, particularly if we identify ourselves as being part of a faith tradition? What are we called to do about it? So that's a big question. Let me break it up into 3 questions to make it a little more palatable. First of all, what are we called to do about this moral crisis by all the examples that are all around us? The second question is, what are we called to do about this by our faith traditions? And the third question is, what are we called to do about this by those who go before us every day? So the first question is, what are we called to do about this moral crisis by the examples all around us? As Reverend Knott mentioned, I teach in a health and human rights clinic and a health and human rights seminar at IU McKinney Law School. I'm part of a health law program there. So it's pretty common for us in various presentations and classes to put a map of the world up that's a map of the healthcare world. And it has 2 different colors on it. Countries are either bright green or bright red. And the bright green countries are the countries that have free universal health care. Now, the bright green countries are all of Europe. The bright green countries are Canada, almost all of South America, Australia, etc. The red countries are the countries that do not have free universal health care. And for the most part, those red countries are very poor countries, sub-Saharan African countries in particular. And the United States of America. The United States of America, where somehow we managed to spend more money on health care per capita. You wouldn't think that based on the stories I just told you, but we spend more money on health care per capita than any society in global history, yet we have some of the worst outcomes of other countries like ours. By outcomes, we're talking about lives, we're talking about maternal mortality, we're talking about infant mortality, we're talking about disease rate, we're talking about huge disparities in disease by income. We're talking about life expectancy. We are sicker and we live shorter lives than folks in other countries like ours. So how is this even possible? You know, what makes us different? Well, here's the biggest difference. The biggest difference is in those green countries, the money they put into healthcare on one end of a pipeline flows through the pipeline, and on the back end it leads to what? Healthcare. Not here. Not here. Not here. On one end of the pipeline, we put more money, again, than any society in global history into our healthcare system. But in the middle of our pipeline, we've got a big, gaping hole. We've got a big, gaping hole in our pipeline that drains out our healthcare dollars for the benefits of some of the largest, most profitable corporations in human history. Our healthcare money is drained out to pay for things like CEO salaries, as much as $83 million for one health insurance CEO, $47 million for a pharmaceutical company CEO. These are leading companies. These folks are leading companies in an industry where people are dying because they can't afford the care. Our healthcare money is drained out of our pipeline to pay for stock buybacks. Stock buybacks enrich the most wealthy investors, including the top executives in these corporations. Our healthcare dollars are drained out of the pipeline to pay for world-leading profit margins, enormous inefficiency in claims processing, health insurance claim denials, and billions of dollars in marketing costs. That's where our money goes. That's where our money goes. Now, you put yourself in the shoes of the folks running those corporations that are benefiting from that gaping hole in our pipeline, and you think, I'm not going to give up that hole in the pipeline very easily, right? So we're starting to hear the fruits of that. We're starting to hear the argument that, well, healthcare would cost more if we plugged up that hole in the pipeline. We can't afford it. As it turns out, all these green countries provide much better care at a much cheaper cost than we have. Well, if we plug up the hole in our pipeline and stop draining our healthcare dollars to private insurance companies and private pharmaceutical companies, for goodness sakes, we're going to have care that's rationed. actually ration care quite a bit less in those other countries than what we have now. Well, we're going to have less choices for our providers, though. Not for most of us. The vast majority of us, if we have a Medicare for all type system, we'd have a lot more choice of where we could go to get our health care. And there's a lot of studies, and we can talk about it. I know we have a discussion period. But the bottom line answer to this question, what are we called to do about this crisis by the examples all around us? The bottom line answer is one of humility. One of humility for those of us in the United States. Because we know we can do better, and we know we can do better because our neighbors around the world are proving it every single day. So that's question number one. What are we called to do about this crisis by the examples all around us? Question number two is, what are we called to do about this by our faith traditions? Now, most of us here in this room, I'm guessing, not everyone, but most of us come from a faith tradition that has at its very core the Good Samaritan parable from the Gospel of Luke. We come from a tradition that's built on centuries of placing the highest possible emphasis on caring for the suffering. There are dozens of New Testament references to Jesus actually performing his own acts of healing, so many that in the early church he was often referred to as the great physician. But this is not just a Christian tradition. Jewish scriptures include healthcare mandates throughout, including in Proverbs and Isaiah. Deuteronomy chapter 15, verse 11, you shall open wide your hand to your brother, to the needy, and to the poor. History's first structured charity hospitals, they were Islamic hospitals. They were Islamic hospitals built by Islamic communities fulfilling that faith's unequivocal mandate to care for the needs of the poor. You can find the same examples in the Buddhist tradition, the Taoist tradition, the Confucian traditions, all the way back to 400 BCE and earlier. Now, all you students here should cover your ears for a minute, because when I was a student here, I'm going to confess to something. There was occasions when I walked into a classroom and I wasn't fully prepared. Now, I would claim otherwise, but I'm pretty old, but there's still some witnesses around that could refute that, right? So I will admit that I came into some classrooms on this beautiful campus and I wasn't fully prepared, but tonight I am. Tonight I'm prepared to talk about the Hanover tradition and the Presbyterian tradition. Now, when I was a student here, I still was in my family's Roman Catholic tradition, so I attended Sunday chapel quite often at the Brown Chapel. I think it was still the Brown Chapel back in the day, the Brown Chapel. But what I knew then, and of course I know now, is that Hanover has its roots, and of course this lecture series has its roots in affiliation with the Presbyterian Church USA. And the Presbyterian Church USA in 2008 made it very clear where it comes down on this topic. That year, the church's General Assembly stated, quote, as followers of our great physician Jesus, we have a moral imperative to work to assure that everyone has full access to health care. Continuing the quote, we are warned by the prophets not to heal the wounds of God's people lightly, yet in 2006, the aggregate profits of the health insurance companies in the United States were $68 billion. During that same year, more than 15,000 families were forced into bankruptcy because of medical expenses, end quote. And then, based on these findings, the General Assembly adopted a recommendation that called for advocacy, that called for education, that pursues, quote, the goal of obtaining legislation that enacts single-payer, universal national health insurance as the program that best responds to the moral imperative of the gospel. The moral imperative of the gospel. Now that's strong stuff, but it's not any stronger than what we see in our scriptures. And by we, I mean folks of all faiths and all moral traditions. And when we look to the scriptures or we look to these more recent statements, where are they pointing to? Who are the prophets pointing to? They're pointing at me. They're pointing at all of you. Because healthcare is not just a job for God to do to perform some occasional miracles to save people. It's not even just a job for the folks who work every day in the field. The scriptures are clear that the welfare of our struggling sisters and brothers, it's the responsibility of every one of us. That's what our faith traditions tell us. Now, to be fair, we have gone part ways on the journey that we've been called to travel. The U.S. faith community can take some justifiable pride in all the charity care that we provide, some of it in the U.S., some of it beyond the U.S. This across all denominations and traditions. But charity is a tricky thing, right? Professor Janet Poppendieck has written that charity can serve as a moral safety valve. She uses the term moral safety valve for our sense of responsibility. We can look and say, oh, well, there's a free clinic down in Madison. I don't know if there is. There's a free clinic down in Madison. Oh, there's going to be some discounts for prescriptions. So the problem is taken care of, right? Well, we know it's not taken care of. We know that the charity we provide today, as wonderful as it is, isn't enough. We know that our best efforts in charity have left enormous gaps in coverage. We know our best efforts in charity left Alex Smith to die. We know our best efforts in charity left Sarah Broughton to die, and tens of thousands of others whose names we don't necessarily know. And that means that we people of faith in the United States and we people of moral traditions in the United States are called to do more than just mere charity. So that's question number 2. What are we called to do by our faith traditions? Question number 3, are what are we called to do about this moral crisis by those who go before us? Part of the real privilege, one of the favorite days of the school year, and we've got a lot of professors here, so they can admit some days are more favorite than others, but students, I know you love every single day that you have a chance to hear from these folks. But one of my favorite days is always the days that we teach about social movements. We teach about human rights movements where the world changes, right? Where things get better, where people come together and make the world a better place. And when you look and start teaching about and talking about social movements, there's a common thread that runs through them. And the common thread is people of faith. The common thread is people of faith who play central roles in the great human rights movement of the modern era. The U.S. Civil Rights Movement, faith community activism central to its success. The anti-apartheid movement, there was a very critical role played by the faith community internationally in particular. The slavery abolition movement, well, of course, the faith community was at the very core of the resistance, as we would call it today. And we certainly know that standing here at an institution founded by Presbyterian and abolitionist John Finley Crowe. We can make this happen again. Faith communities can do this again. And we can especially do that when it comes to healthcare. You know why? Because we have been blessed with the moral authority on healthcare because of the folks who've gone before us, the folks who in the name of their faiths have provided medicine, have provided care, have conducted surgeries, have gone out in public health outreach. We have our sisters and brothers who have gone out. I'm talking about folks in our communities who are LPNs, licensed clinical social workers, RNs, psychologists, physicians, etc. And if you or others in your family are in that category, thank you. Thank you, because it's so important as showing the model for the rest of us. But it's not going to be just direct care, right? Faith community activism is just that, activism. So the question is, what is that legacy of faith community activism? What does it call for me and you to do? What are we called to do? Well, I need to decide that for myself, and you need to decide that for yourself, and it's going to look different for most of us than it is for the others in this room. But as we ponder that question, I will say we're blessed with some guidance. We have role models who are all around us to give us guidance, because we have many sisters and brothers in our faith communities today who are already taking action. They are living out the Good Samaritan parable. They are refusing to walk past the bleeding man beside the road to Jericho. They know that a version of the golden rule is at the very core of every single faith tradition. Now, I've been blessed, and thank you to Reverend Knott for mentioning it. I'm blessed with being a part of a big, new, exciting project, and that is a publication, a weekly publication called Faith in Healthcare. And Faith in Healthcare is a free weekly publication sent by email. It's also circulated out on social media, etc., every Thursday morning. If you're interested, our website is faithinhealthcare.org, all one word, faithinhealthcare.org. You can look at past issues. You can sign up for the free weekly delivery if you'd like to learn more or be connected with us. Because our publication lifts up those people of faith, those people who refuse to look away and walk on when they see the person struggling at the side of the road. We have already had the blessing to interview Will Cook. Some folks in this room may know Will Cook. Will Cook is a physician who does his work just a few miles up the road here in Scott County. He's a Christian physician and an activist and a healer. He responds to the needs of Hoosiers with addictions and Hoosiers infected with hepatitis and HIV here in rural southern Indiana, and he insists that they deserve better. We've had a chance to interview Maureen Karim. Maureen Karim is a young woman who responds to the needs of Muslim women around this country for reproductive health services and education, and we're going to be featuring the director of the American Muslim Health Professionals in his upcoming issue. We've had a chance to interview Nathan Bennett, a Jewish activist on Capitol Hill who helped mobilize a mighty interfaith advocacy coalition. Sister Simone, who spoke to this in this series, was part of that. An interfaith advocacy coalition that literally took over Capitol Hill and held all-night vigils, and we talked about rabbis, imams, and priests, and nuns, and ministers who stood up together and said, don't take away the Affordable Care Act. The Affordable Care Act isn't perfect, but people are relying on it. People are surviving because of the Affordable Care Act. Don't you dare, members of Congress, take this away. And they won. And they won. They succeeded. And Nathan was a big part of organizing that. We've also had a chance to dive a little bit deeper into the faith community history for activism for healthcare. And part of that dive has been into the Canadian system. A lot of times when folks talk about how our U.S. system can improve and change, they look at the Canadian system. And if you know a little bit about it, the father of the Canadian healthcare system is a man named Tommy Douglas. Now, if you know anything about it, Tommy Douglas pushed through the Canadian healthcare system when he was the Premier of Saskatchewan. Premier is essentially a governor analog. He was the leader of the province of Saskatchewan. They created a free universal healthcare system in that province first, and then were able to expand it to the entire country. Now, folks know that about Tommy Douglas, but they don't know what his first day job was. His first day job was he was a Baptist minister. He was a Baptist minister raised in the social gospel tradition who kind of reluctantly got into politics because he was caring for the poor and serving for the poor and advocating for the poor and thought, well, wait a minute, I think I can get a lot accomplished over here. And when he pushed through the Canadian healthcare system, he did so with an interfaith coalition across the entire country. Now, there's a lot of talk about the Canadian healthcare system these days, especially if we consider whether we're going to change things here in the United States. But let me just make two observations tonight. The first is this: when Canadians are asked about their healthcare system, they are deeply and profoundly proud of it. When they are asked, and polling shows this, what they are most proud of about their country, they will rank their healthcare system number one. Like hockey is number two, right? It actually beats hockey. And Tommy Douglas has actually been voted as the most significant Canadian, the greatest Canadian in history because of what he did. The second observation is this: it's not a perfect system. No system is perfect, and if we had Canadians here, they could tell you about some of the ways that it could improve. But it is a system where Alex Smith wouldn't have died. It is a system where Sarah Broughton wouldn't have died. It is a system where Hedda Martin wouldn't have been told, hey, why don't you get a jar and put it by the convenience store counter and tape your picture on there and say, hey, if you got special extra change after you get your gum, can you help me pay for my life-saving surgery? That would not happen in that system the way it happens here. In fact, as one faith community advocate in Canada called it, she said their universal healthcare system is the Good Samaritan writ large. Because we can't all find the people at the side of the road, right? So in this Faith in Healthcare publication, we have the enormous privilege of lifting up these inspiring people of faith. But they would be the first ones to tell you, if you have them standing up here instead of me, they'd be the first ones to tell you they're not superheroes. They're not gods on earth. They are ordinary people like you and me with one difference, is that every day they make a choice. They make a choice to take notice when our sisters and brothers are suffering. They make a choice to remember the scriptures and the faith traditions. They make a choice to listen when they are called to take action, even though that action takes different forms for all of them, just like it's going to take different forms for all of us going forward. because they believe what Lisa Hayes believes. Now, Lisa is an African-American woman from Indianapolis who I actually knew in a prior professional life. But what I didn't know is that several years ago, Lisa found a lump in her breast. And she found a lump in her breast at a time when she and her husband were both between jobs and without insurance. She had breast cancer. She was lucky enough to get help. She was lucky enough to get treatment. And when she finished her treatment, Lisa made her choice. She left behind a very prestigious legal career to devote her life 100% to being an advocate for other African American women with breast cancer, women who have a far higher mortality rate than white women with the same diagnosis. Why did Lisa Hayes make this choice? We asked her, and here's what she told us. Quote, "God did not spare my life so I could sit around being happy to be a survivor. God spared my life for a reason. God spared my life for a reason." Now, I, for one, believer, and I'm guessing a lot of you in this room believer too. And I believe something else. I believe that God didn't just spare Lisa for a reason. God, however we envision God, spared all of us for a reason too. Because this is an important place, an important time. God put us here in this country. This country is not perfect. This country is, we can list that. We can spend all of our rest of the time listening to the ways our country is not perfect. But this country is a part of a democratic system where our leaders are accountable to us. If there's nothing that you take away from the lessons of social movements in this country, is our leaders will make changes sometimes they vow they're not going to make if we push them hard enough. And we have the capacity to do that in this system. And God put us in this country for a reason. God put us here now during this time of opportunity for a reason. This is a time where the moral crisis of our healthcare debacle has become absolutely undeniable. The pressure has been building and building and building and bubbling up, and my guess is if we do ask the folks around this room, we know folks who have struggled because of our messed up healthcare system. And that has generated a demand for change. Polls show that a majority of Republicans and Democrats support a system like a Medicare for All system. Republicans and Democrats. So do a majority of physicians. So do a majority of nurses. So do a majority of healthcare executives, believe it or not, from recent polling. Business owners are coming together and organizing, saying, you know what, we don't want this on our shoulders anymore. Healthcare should not be subject to what kind of job people have or what kind of premiums that a small business owner can afford. The time is ripe for change, so God put us here on this particular day and age for a reason. And finally, I'd say this. I believe that God put us here at Hanover College for a reason. Here in a place where we are blessed to have connections to this community, connections to your congregations, connections to our family. The Presbyterian Church USA, with this strong stance on healthcare, is not an outlier. Other faith communities across the spectrum of Christianity, of Islam, of Judaism, and beyond, they are lining up to take a stand for universal health care as a moral imperative and a human right. So God put us in our own communities, our college community, our faith communities, for a reason. Tonight it's too late to save Alex Smith. Tonight it's too late to save Sarah Broughton. But it is not too late to save millions of others. It's not too late to save those millions that may include our neighbors, it may include our loved ones, it may include us. And it's not too late for you and I to make our choice. A choice to listen to our faith's call to action, a call to finally confront this moral crisis, and to once and for all make it stop. Thank you. So we have time for folks for discussion, and I think can I stand out here and not mess you all up? Okay. And then the public online is going to want to see me, right? So I want to make sure. So do folks have thoughts, questions, comments, stories? Yes, sir.
Would Medicare for All result in the end of private insurance?
So, yeah, go ahead.
Where would all those jobs go? Because
Yep.
I got a buddy of mine who, his mom works in insurance, and he's struggling to get through college as it is now. I just want to make sure he'd be all right.
Yeah, that's a completely good question. And again, I think you can't hear it online, so I'm going to say it out loud. Is that the question is, would a Medicare for All program eliminate private insurance industry? And what about the tens of thousands, if not hundreds of thousands of jobs connected to that? The answer is that the Medicare for All programs that have been proposed, they can range quite a bit, but the kind of pure ones, and in my view, the ones that are most likely to solve the issues that we have, would eliminate private insurance companies. They also do include the congressional proposals on the U.S. House side and the U.S. Senate side, a fair amount of dollars set aside for reemployment, retraining, early retirement, et cetera. Understanding, I'm from Indianapolis, right? Anthem is located in Indianapolis. People's lives, people are paying their mortgage, paying college tuition. You can't just leave these folks to the side of the road when you have this transition. It would be a transition that we need to take care of those folks. Those are our sisters and brothers too. So yeah.
Would it be too difficult for you to use the mic?
I think I have one here, right? Okay.
That's fine.
If you prefer, I'm here.
I'm needing as much help as I can get.
Okay.
So, thank you.
Okay.
That doesn't come through the speaker, though. That was just for the people.
Oh, so I should be here. Okay.
Or, yeah.
This is better. Okay, good. All right. I'll hide behind the podium.
Okay, my question is, since I'm on Medicare now, but would people still, so I have a supplement that goes with that, which is with a regular insurance company. Would that be the way that it would probably work? That people would get supplements then, or?
Right. The question was, what for Medicare Now, if folks don't know, and we got a lot of folks who aren't as old as I am in this room, so to tell you Medicare Now does leave gaps, right? Medicare for All, Medicare Now does, folks need to buy supplemental plans, there's deductibles, there's co-pays, especially in the area of prescription drugs, et cetera. So the actual legislation, Medicare for All, because it goes to your point a little bit, Medicare for All is a broad term. The actual legislation is usually named Improved and Expanded Medicare for All. So improved and expanded Medicare for All would eliminate the co-pays, would eliminate the deductibles, would be frankly much stronger than existing Medicare. And Medicare, of course, is very popular. That's the reason it's called Medicare for All. This is folks who are smarter than me making a choice of what's going to be a sellable and understandable description of the program. But Medicare for All proposals, a single payer system like you have in Canada, for instance, no such thing as co-pays, deductibles, et cetera. So those would go away. But what would stay the same is you have a card, right? We would have a card in our wallet that would be our Medicare for All card, and we could go to any provider, and that would be the single payer is the United States government. So we wouldn't have to say, oh, who's going to be in our network? We wouldn't have to worry about paying our co-pays, deductibles, et cetera. That's how that would work. So again, it would be different from and improved from the existing Medicare system. But the existing Medicare system, part of the reason it's popular is that it is actually, you do have a lot of portability with it, and also it is enormously efficient compared to private insurance companies because they don't have to spend the money to deny claims and market and try to sell their policies. And CEOs don't get paid $83 million in the Medicare program, right?
My question is, do you know how well the trainers of public health professionals, doctors, are talking about this, are educating the future health providers about this, are contemplating public health in general with that kind of system?
Right.
Good question, Janet.
So the question is, for those who couldn't hear it, if anybody couldn't, and I guess I think it's mostly folks online who couldn't hear it, because you don't need a microphone, you got it. You're a professor. Is what about public health professionals? What about health professionals? And what about the training for the future professionals? Well, I guess let me answer that in two parts. One is that some of the leaders of the movement to make a change here, some of the most articulate, dedicated, impactful leaders are folks who are direct care providers. Physicians for a National Health Plan has been pounding this drum for decades and very successfully raising the awareness, and they have managed to reach that tipping point now where most physicians say this is what we should have. National Nurses United and other nurses unions have done a great job of organizing around this too. But to your question, to part of your question about our future healthcare professionals being educated about this themselves, there are student versions of those. I don't teach in those schools very often. I guest lecture sometimes, but my understanding, especially in med school, not a lot of policy. Just a few years ago, I participated in a day-long seminar about the Affordable Care Act when there was talk of repealing and replacing it, because students who were third and fourth year med students, they organized it themselves because they didn't know what the Affordable Care Act was. They're busy, right? They're learning how to save our lives, right? So we're going to be glad for the work that they've done, but they haven't included policy much in it. But what's interesting to see is organically the profession and students are starting to educate themselves, have the teach-ins, pull in folks for seminars and discussions. So it's happening a lot more organically than institutionally as far as I can tell.
I'm curious, what about the American Medical Association? Where do they stand?
Well, the American Medical Association has traditionally been a vociferous opponent of single-payer health care. They have worried that this would interfere with physicians' incomes and at least say that they're worried about the autonomy. They talk about things like socialized medicine. It actually wouldn't be that, because the physicians would still work for themselves or whatever it's just who's paying them would be the U.S. government. Even more so than now, right? With the U.S. government through Medicaid, Medicare, VA, et cetera, is paying for quite a bit of the health care we have now. So the AMA has not supported Medicare for all now. I think there's reason to hope that in the relatively near future that might change, because what used to be a strident opponent of it has taken a half step back because they're responding to their constituency. They're responding to physicians. And physicians, if you had them in the room, I don't know if we have a physician in the room, but they'll talk about it. Number one, they're committed to the care of their patients, and the current system doesn't do that well. But number two is they didn't sign up to spend 40% of their time filling out forms, right? They didn't sign up to have their entire entity dependent on people arguing with insurance companies. And you see the parallels between a Canadian hospital that has one person who presses a button to get the bills paid versus a U.S. hospital that has entire teams, office suites full of people to wrangle with insurance companies to try to get payment. So not there yet. I think there's reason to be hopeful, and partly is because this younger generation of physicians coming up saying, this is not what we want. And the younger generation, frankly, all of you, your younger generation is much, much more open to this than my generation has been. That's you and you.
Do you think that hospitals and physicians' clinics would have an increased wait time since people would be going more often?
Yeah, there's going to be, that's a great point. I don't know if everybody's heard that. Is that will hospitals and clinics have an increased wait time because more people will be going more often? That's going to be part of the adjustment period, right? Is it not that all of a sudden things are going to be different for those who get health care? Is it that those who don't get health care now will be going to get their health care, and that's going to be an increased demand. And so that has to be part of the equation. There's been not enough done on how to pay for this, right? It is overall going to cost a lot less money, but the lot less money means that we're not going to pay premiums and copays and deductibles. So the government dollars that we pay now are going to have to increase to cover at least part of that. Not all of it, because we'll still save overall. So that's going to have to be baked in to how much. So we will have an increased demand. And if we don't increase our capacity, then there could be. I think, but when you talk about wait times, I know it's not your question, but let me just address it, because that's a pretty common talking point against this, is that, oh, people have to wait so long. In Canada, if you need bypass surgery, you got to wait 18 months for that to happen. It's just not true. For elective, non-emergency surgery, sometimes people have to wait. For emergency needs, people do not. It's Canada, UK, Japan, et cetera, all these green countries I mentioned. So we're going to need to make sure that we do respond immediately to emergency needs and quickly to urgent needs. But yeah, we're going to have to increase capacity. But that's also, to answer your question, some of the question, what do we do with all these folks who work in the private health insurance industry now? Ideally, it's not going to happen for everybody because people are different ages and capacity. But the ideal, right, is you take somebody who works for Anthem now denying claims and you move them over and they work for IU Health or something, helping provide the increased care. That would be a great transition. And of course, we have folks in our communities who could use good paying jobs. So if we can create these good paying jobs in the healthcare industry, that's a win-win. So you go, yeah.
So how would physicians be compensated? Are they still going to be compensated on a per patient, like per procedure basis, or would they receive a salary?
No, so this is the difference between the, the question was how would physicians be compensated under this program. So let me just say this, take a half step back. We don't know what it's going to look like, right? We don't know, the sausage making has a lot more to churning to happen before we know what it looks like. But the Medicare for All proposals, the one that have the most support, the one that have the most support in Congress and in the public, are analogous to the Canadian system. And in the Canadian system, physicians work privately. Physicians work for themselves or for healthcare companies or companies. And so they would get reimbursed, similar to what they get now. And again, many physicians are reimbursed by Medicare or Medicaid or whatever now. So it would be physicians being reimbursed by the single payer, and the single payer is the U.S. government. And again, that's oftentimes the payer now. Now, the UK system is rightly called, quote unquote, socialized medicine, because the physicians there do work for the government, right? And the hospitals are government hospitals. So that's the difference. That is not a proposal that I ever, that right now has any traction in the United States, because it does, it flies in the face of our political culture, right? We're individualistic here. We don't want the government to take everything over. So when the idea is the government's going to take everything over, that's the UK system. The single payer Canadian system is folks still work for who they work for, but they're going to get paid by the government. And nobody ever really objects to getting paid by the government. At least I don't. I work for Indiana University. I'll take their paychecks all the time. So. And I'm sorry, you handled it. Yep.
When Trump was campaigning, he promised that he would be the only Republican who would not cut Medicare. And then, of course, in the 2016 budget proposal, he did. So I guess my question is, how do we hold Republicans accountable when they make promises to rural areas and then get elected and betray them?
Right. The question is, how do we hold folks accountable when they make these promises? Because nobody ever runs on, I'm going to cut Medicare, I'm going to cut Social Security, et cetera. They usually, they obviously run on the opposite. I don't want to be simplistic, but the answers are every couple of Novembers, right? That we have the ability to, we have the responsibility to hold them and remind them of what they've said, and not just let folks get away with the promises that they haven't fulfilled. And that's true, of course, of both parties. People make promises they're not fulfilling. But yeah, I think that one of the reasons I'm really optimistic is that people are increasingly literate. In my professional career in dealing with folks who are struggling to get health care, people are increasingly literate about what the health care issues are. They're increasingly frustrated about what the health care issues are, and they vote that way. In the 2018 elections, a lot of the support that Democrats have received, a lot of folks have attributed that to the folks that's a party that people felt more comfortable trusting their health care to. Did you have a follow-up to?
Just that I was thinking about national movements and the Women's March and the March for Our Lives, and I wonder if healthcare is something that we can rally around nationally.
Yeah, I hope so, and I do think so. We're at a stage that's a bit of a transitional stage in that the congressional sponsor, the main congressional sponsor in the U.S. House of Representatives for Medicare for All, left the House. He's now the Attorney General of Minnesota. So it's a new sponsor, Congresswoman Jayapal. And so the legislation just did get introduced like 3 weeks ago. So it's just getting started. It's clearly an issue on the presidential, 2020 presidential election. I personally think there's mixed feelings about that, because when it's a presidential election issue, it's less likely that people are going to flood the streets. So we've got some work to do, and I do think that's where the faith community has a really important role to play, because like care providers, but maybe even in a special way, faith community can make this a moral question. It's not just a dollars and cents question. It's not even just a here's a logical way to provide this public good. It's this is a moral imperative and a human right, and we are going to take action. And I mentioned that story about the interfaith group conducting their vigil and their rally outside of the Capitol during the waning days of the effort to repeal the Affordable Care Act. At the same time, they were mobilizing people to flood their members of Congress with calls and letters, et cetera. That's a wonderful model for us to build from. We got to get better and we got to get bigger, but I think there's a prospect, but I do think the faith community has a role to play in. Yeah. Absolutely, absolutely. I thought I saw another hand up. Yep.
So with all these insurance companies making $83 million a year, they have a lot of money to buy as many politicians as they want. So with so much lobbying, it seems like politicians are in the pocket of the money and not, if 75% of, according to the latest, well, 75% of Americans support single payer system, but we don't have politicians supporting it. How do we get that money out of politics? Because that's the major part.
Right.
We can all say we want it, and we vote for them, and then they go and, as one of the audience members said, they go and just go against what they promised. So how do we get that? Because insurance companies have a lot of money. It seems like more money, more votes.
Right.
Instead of one person, one vote.
Right.
$1, whatever.
Yeah, that's, obviously that's the challenge, and especially when you talk about private health insurance companies, because to your original question, this is an existential question for that industry. And if they've got all this money, they're going to spend every nickel of it to try to stop this, or to co-opt it. Because already our Medicare program, Medicaid program funnels a lot of money to private insurance companies now. And so that's actually getting a lot of traction, saying, okay, we can have universal health care, but we're going to keep private insurance companies in the middle of it, and the government's going to pay the private insurance companies. For what reason economically? I'll defer to the economics professor about what reason, I don't know. But yeah, that's our challenge, right? That's our challenge. But I think the answer is this. I think the answer is you look to the histories of social movements when it always seemed impossible. And I think you look to the idea, all this money in the system, and clearly we need to address that. I mean, none of it is more powerful than 50.1%. When those people running for office believe they will be beat because they have people in their district who will vote against them because they're not supporting a change in our healthcare system, it doesn't matter how much money Anthem or whoever is going to, or the pharmaceutical companies are going to put in. And as for a very recent story, the recent story, some of you may have seen this, we talked about insulin. Eli Lilly and Company from my hometown of Indianapolis, Indiana, for 20 years kept raising the price. Raising the price for a vial of insulin cost them $5 to make, and they kept raising it and raising it and raising it until it was almost $300. But people started protesting. Nicole Smith-Holt, the reason she stayed at our home was she was part of a protest where she and her husband put some of Alex's ashes into the flower beds in front of Eli Lilly and Company. Media kept covering this. There's been pushing politicians from both sides of the aisle, that includes President Trump, saying we got to do something about drug prices. I don't know if you saw this, 3 weeks ago, Eli Lilly said they're going to cut their insulin price in half after 20 years of relentlessly raising. Now, it's not low enough. It's not going to apply to everybody it needs to apply to. It's still an obscene amount of profit, but it does show that the advocacy is working. And that is an industry that spends more money on lobbying and more money on political contributions than anybody else. And if they are subject to the will of the people, everybody else is too. Yes, ma'am.
How can we leave here knowing that this message is going to become writ large here on this campus? I mean, what can we do that are sitting right here hearing you? Because it's a very important message for the whole campus.
Yep.
And I don't think we have a newsletter on this campus. So how do we get the word out? You know, I think it's really important that everybody know that these are very, in a way, easy steps if you know about them and if you know how to think that way.
Right. To answer your question, a full spectrum of reproductive health care is covered under the Medicare for All House bill that's been proposed. So yes. And if you think about that, the answer is usually, almost is always yes. It's dental care, things that are hard to get funded now. You know, this is the ideal piece of legislation. It does cover all of the needs. And to answer your question, Mrs. Rogers, Well, I'm definitely open for others' ideas of how to do this on this campus. What we created this publication, Faith in Healthcare, to do is to lift up all the folks who are already doing this and spread it out so that hundreds and then thousands and tens of thousands of people of faith. And you know, you're a member of the Presbyterian Church, I know, and the Presbyterian Church USA deserves enormous credit, thanks, and support.
Very good
Yeah.
idea.
They need the support. They've said the right things. Had they taken a lot of tangible action, they could do more. And every other faith community could do more. Yes, ma'am.
So as a current Hanover student, I'm just curious to know how your experience at Hanover influenced the work that you're doing now.
Oh, that's a great question. Back in the Stone Age when I was at Hanover College. So I don't know if everybody could hear. The question was, how did my time at Hanover influence what I do now? So we all have tools in our toolbox. We all have things that we do well and best. And I think that what I do best, and that's true for a lot of lawyers, definitely true for a lot of law professors, probably all kinds of professors, is that I write and I speak. And I got a whole heck of a lot of that training here. I was an English major. I wrote a lot. I had what I wrote be critiqued. I read a lot. I had what I read, I had to, you know, pass exams, mostly pass exams on. Nobody look up the transcript, please. So I do think that what it did do, I can't say that I walked out of here, you know, you can't come to your alma mater and ever claim what your different age, right? You say 1984, people can do the math about how old you are. So Reverend Not told you 1984, so you know that it was May of 1984. I didn't know I was going to be doing this. In fact, I do not have a healthcare background, right? I don't have an RN, I don't have an LPN, I don't have an MD or anything like that. What I got was a law degree and I started representing poor people with their legal problems, and poor people problems in this country and around the world, but particularly in this country, are often healthcare problems. And that led me to being a healthcare advocate. But what I do think the liberal arts education did is prepare me to learn, right? The whole idea is you're learning to learn, and I learned how to teach myself some of these issues of healthcare and healthcare policy, et cetera. So I didn't know what I was going to be doing. I certainly didn't know I was going to be doing this when I walked out of here in May of 1984, but I'm grateful to this institution for preparing me to do it, even though I didn't know what I was being prepared for.
This is sort of an English major question coming from the foreigner.
Uh-oh.
Okay, but since socialist, socialized, socials, those three words in the press get thrown around as if they were candy and, you know, cheaper than a penny. And nobody's, and carelessly, irresponsibly, and very often so with such neglect that the meanings of these words are getting completely distorted. And so, since I'm a little bit obsessed with word choices, but also with facts, I wanted to ask, what do you think are the three most damaging misconceptions this country has about social health care?
Oh, three most. Let's see if I can get to three.
It's only three.
Right, three. I think we've heard some of those, right? We've heard some of those here, and they say folks are saying they believe them. But number one is that the government is going to decide what health care we get and when. There's going to be death panels. We're not going to be able to get the care that we need. The socialized health care is going to mean that we are going to lose autonomy, and there will be others making decisions for us about our health care. When, of course, that happens now, it's just the person's making the decision sit in a high-rise penthouse suite, right? Yeah, making those decisions now. And we don't have any influence. And if the system that is created is not to our liking, then we have an influence every other November, right? We have a chance to make a change. So that'd be number one. Number two, I think, is this idea that, oh my gosh, it's going to cost so much. And that is pretty maddening, right? Because that's just willfully ignoring the fact that, yes, we will pay more in taxes, but we're going to pay a whole lot less in total than we pay now. I mean, it's just, you know, that's just in my view, a completely dishonest argument. You look at every study, including the Mercatus Center, you know, a very libertarian, almost right-wing study, is like, yeah, we're going to spend a lot more dollars under Medicare for All of government dollars, but we're going to spend a whole lot less than we're paying on, March 25th, 2019. And then I do think the question raised about, what about physicians? What about healthcare providers? Are they going to work for the government? Now, again, it depends on you. This is where word choice happens, where policy choice happens, right? Is that if we take a UK system, then healthcare providers do work for the government. But that's not what's being proposed here in the US. So I do think cost, autonomy are the big issues. Do you have other ones you'd want to suggest?
Because it's a very perverse way of putting a very low dollar amount on people's lives. The health insurance and pharmaceutical companies spent $1 trillion lobbying against the Affordable Care Act. That could have funded the whole thing.
Yeah. We pay plenty of money for healthcare now. That's not a question. Sometimes the question is, where are you going to find the money if you want to talk about affordable housing? We're going to talk about, the refugee crisis. Something like, where are you going to find the money to fix that? In healthcare, we don't have to say where are we going to find the money to fix it. It's like, how are we going to get the money out of their hands? It's more than enough, and put it here for our healthcare. And that's not easy. To the point that's going to be a fight.
What other countries have where health insurance is a profitable business in the world? Is it just the US or are there other countries?
Well, there's some European countries that have some place for, Germany in particular, I think France as well, that have some place for insurance companies. Sometimes they're not-for-profit insurance companies. They're, the government guarantee undergirding it. And so sometimes you see folks saying, oh, we can't shoot for the stars of the Canadian system. We need to look at something like Germany or France that include private insurance companies. So I can tell you personally, I'm of two minds about that. The first is the policy advocacy mind. It's like, why would we keep in the system the broken part of the system, which is the for-profit nature of something that's not, you can be a market person, and lots of people who are pro-market persons think healthcare is not a market entity, right? Healthcare is not something, if I, drop with a heart attack down here, I'm not going to negotiate which hospital I'm going to go to and which ambulance I'm going to be carried there by. So, yeah, I mean, yeah, let me leave it there. Is that
Yeah, I'm
just leave
sure
it?
because it seems like our healthcare system is so out of whack any other system in the world.
Yeah. So I guess so I do think, why would we do that? I forgot. I was going to say the second mind. The second mind is that my job at the law school clinic, and frankly, it's probably true of anybody, is I know people who don't have good health care now, right? I know people who don't have good health insurance now, can't afford it. We know Nicole who lost her son. We know other people who've lost loved ones. I don't think it's fair for me to say, if we've got a system that looks more like Germany and France, but everybody gets covered and we're still going to preserve something for the private insurance company, that's not okay. What you worry about is if we have a system like that where we preserve the private insurance company, what are they going to do? To the point over here, they're going to keep lobbying for a bigger piece of the pie, and they're going to keep pushing for their part, the insurance they're providing, to be a Cadillac version, for the rest of us to have a poorer version. We know this from every public benefit program we have now. Social Security, people don't touch, right? Politicians don't touch. Medicare, people don't, or they promise they're not going to touch it, right? Because they're universal programs. Our clients are on SNAP, food stamps. Our clients are, sometimes get TANF, temporary assistance to needy families. Those things are constantly at risk because it's only a few people those apply to, relatively powerless people. If the care is universal, if the system is universal, and then we're all going to fight for it. We're all going to have a piece of it. So, yeah, it just makes, except for political expediency, I see no justification whatever to keep that hole in our system open, right?
They still got the biggest houses in town.
Yeah. Other question? Yeah.
Has there been any examples of any other countries that have been in the system like the United States that have moved on into free healthcare or like more accessible healthcare? Because I just wonder, is it realistic that the United States, being such a capitalistic country, to move on forward to a free healthcare system?
Right, that's a great question. The question was about the transition. That's, we're going to have to make history, right? We're going to have to do that. But Canadians did. And who opposed the Canadian system that Tommy Douglas and the faith community helped build? Physicians, insurance companies. right? Not to the extent in the entrenched, huge dollars that we see now, but big dollars, and they were fighting, they fought, and they never compromised and said, okay. They fought and they were defeated by the people who were demanding a better system. So, yeah, and I think that's a bit of a model for us, but I think some of the other models come from other social movements, which seemed, it seemed impossible that women were going to get the vote, right? It seemed impossible we're going to prohibit child labor. It seemed impossible we're going to get rid of slavery. It's economically unfeasible to do these things. And eventually it happens, and maybe not in my lifetime, but in yours, right? So.
Yeah. May I check on an example that I read once, but I don't know anyplace else, but it raises intriguing questions. Like, how is it that the British were able to do national health care following the Blitz? One answer that I've seen is the experience in the underground during the Blitz brought the community together in a way that would
Oh, interesting.
your Good Samaritan
Yeah.
point that we are, all vulnerable.
Right.
And we all need to take care of everybody.
Oh, that's a...
Do you think that there's some historical analysis that would support? I'm intrigued very much by it wasn't when they were the wealthiest and rule the world, but
Right.
when they were on their knees
Right.
that they developed this policy.
That's a great point. So I'm a lawyer, and I never hear the most optimistic versions. I hear the crass version. Right? And the crass version you hear is that, our big problem is that we have this employer-based health insurance system, right? And we have the employer-based health insurance system tracing back to World War II with price controls and salary controls, and the way that private industry competed for good employees was to say, hey, we'll provide you health insurance. We'll provide you a better health insurance. And then, for the period post-war, we were booming and everything was looking good economically. But of course, the British system didn't have that, right? And none of the European systems had that baked-in employer-based. And I think it's actually really, there's a free movie out there called Fix It, and F-I-X-I-T, and Fix It is the business side argument. It's actually the sponsor of the film and the kind of narrator and star of the film, if you will, is a man who owns a Pennsylvania frame making company. But his company is getting absolutely slammed with health insurance premiums year after year after year.
All liberal arts colleges too.
Yeah, and he's saying, why are we doing this? And then he interviews folks from other countries like Canada saying, look, I'm politically conservative, but healthcare is not something that we rely on every single employer to provide. So if you talk to especially small and medium-sized employers, they're like, oh my gosh, this is a nightmare. And they are increasingly standing up saying, okay, this was created because in 1942 it was a way for us to get employees, right? But this is 2019, it doesn't work anymore. Let's follow what the rest of the world is doing. So that's the crass version. I like your version better, the esprit de corps of the British people. Any other questions or comments? All right, I've exhausted everybody, so thank you. Thank you.